So hi guys and welcome to MedCatlist classes. So in this classes or in this session we'll be discussing about pediatrics like a rapid revision sequence. So I will be teaching about pediatrics, all the aspects of an pediatrics that will be very helpful for your exams. And let's discuss now like this integrated system. So in the systems we'll be going cardio, nephro, neuro and all. So let's discuss about pediatric cardiology. In the pediatric cardiology, most of the students they will be feeling tough to understand this concept, so I will be teaching in a very simplified manner, so which will be helpful for your exams. And if you know, like if anybody asks, let's move on to the cardiology discussion. Which is the overall most common heart disease? Like acyanotic heart disease. And in that also overall, which is the most common heart disease? Like yes, that is acyanotic, and best variant is like VSD, ventricular septal defect. This is the overall most common acyanotic heart disease or heart disease. Okay, and if they ask which is the most common cyanotic heart disease, yes, if they ask cyanotic, that is your top tetralogy of Fallot. Okay, and overall I am repeating the sentence, overall which is the most common acyanotic, which variety of an acyanotic? That is the VSD, ventricular septal defect. Okay, and if they ask most common cyanotic heart disease in neonates, your answer will be TGA. Okay, transposition of great artery. Okay, and now let's move to the acyanotic heart disease. So what are all included in this acyanotic heart diseases is, one is your ventricular septal defect VSD, and next one is your ASD, atrial septal defect, and next one is your patent ductus arteriosus. So in all these conditions there will be an increased blood flow. Okay, blood flow will get increased. And one more type of an acyanotic heart disease is your COA, which is like coarctation of aorta. I will be teaching in subsequent slides. So what do you mean by this? But remember, these are all the acyanotic heart disease. So this is an example for obstructive lesion. Okay, so these are all examples of acyanotic heart disease. So now let's discuss about each and every disease. Like VSD. VSD is nothing but ventricular septal defect. So I will draw a simple diagram for you. So this is an heart. This is an right atrium, right ventricle and left ventricle. Ventricular septal defect is nothing but here there is an opening between the left ventricle to right ventricle. So that's why blood is moving from left to right. In all these conditions, no, in the above condition, blood is moving from left to right. So that's why this is also known as left to right shunts. Okay, and this is about VSD. VSD is nothing but abnormal connection or gap between the ventricles. Okay, interventricular septum. No, here there is a gap, so that's why blood will be moving from the left ventricle to right ventricle. So what is the different varieties are present? No, so like we know VSD is the overall most common variety, and there are a lot of types of an VIT, that is peri membranous VSD, peri membranous VSD. Okay, so this is the overall most common VSD. This is a subtype of an VSD, that is perimembranous VSD. Perimembranous is nothing but if the hole is present in this upper part. No, this is known as perimembranous VSD. Okay, that is known as perimembranous, and this is the overall most common variety. And next is like muscular variety. So I will be teaching only important aspects, like what do you mean by this muscular? Why I have mentioned this muscular is, this is the VSD which doesn't require any treatment. So that's why there is a high chances of spontaneous closure. Spontaneous closure. Okay. So this does not require any treatment. They will close us spontaneously. Okay. This is about muscular type. So what are all the clinical findings that you will be encountered in VSD? Yes, tell me. The blood is moving from left ventricle to right ventricle. No, so that's why when it is moving, like you will be hearing some murmur. So what kind of murmur is seen is pansystolic murmur. Very very important. So which kind of a murmur is present in ventricular septal defect? Pansystolic murmur is present. Okay, this is about very important. Like, what do you mean by this pan? Pan is nothing but throughout systole. Throughout the systole, the murmur is coming. That is known as, is seen in ventricular septal defect. Okay. So how do you treat the condition? By through the surgery. Okay. So surgery. So how you can put a patch over there, that is known as patch closure. Patch closure surgery. So best example is Dacron. Okay, and you can also put the valve and you can also close that condition. Okay, and next we move to the one more condition, that is known as atrial septal defect. So here what happening, I will write it for you. So here, so this is the four chambered heart, right atrium, left atrium. Here abnormal connection is present between the left atrium and right atrium. Okay, that is known as atrial septal defect. Okay, there are two types of an atrial septal defect, that is ostium secundum, and next one is ostium primum. Okay, so this is nothing but, we overall, which is the most common type of an ASD? This is the most common, ostium secundum. This they have been asked. And what kind of an heart sounds you are going to see in this? Second heart sound. No, which is second heart sound? Here it is wide and fixed. Okay, this is the characteristic feature that you will be seeing in the ASD. Okay, these murmurs are very, very important in acyanotic heart diseases. Okay, and next, how do you treat the condition? Just tell me treatment. How? Look at the size. If the size of an ASD is less than 8 mm, okay, so what you are going to do is just observe. It will close spontaneously. If it is not, if anybody asks when the surgery of ASD should be done, before school going, no, when does the child actually go for the school? At 4 years, no, so that's why we should do the surgery before 4 years. Before 4 years. Okay, and next we move to the size. If the size is greater than 8 mm, same, which I have explained earlier, that is patch closure. Okay, patch closure. And next is also like by the passing through the catheter, that is also catheter closure. Okay, so this is about treatment of ASD. Remember ASD, like they have been asked, which is the most common type of an ASD is ostium secundum. Okay, so this is about ASD. And next, PDA. What do you mean by this? PDA is nothing but patent ductus arteriosus. Okay, so now let's see what happened. So can you tell me which is the infection? This they will be asking very frequently. No, your rubella. Rubella infection is associated with patent ductus arteriosus. In one word, if you want to rule out whether it is an PDA, is like I taught you, murmur. So how? Here what you are going to see, which kind of a murmur? Continuous murmur. Continuous missionary murmur. So what do you mean by this PDA, patent ductus arteriosus, is nothing but, so I will draw you for you diagram. So these are the chambers, left atrium, left ventricle, right atrium and right ventricle, and this is the aorta. And remember, this is the pulmonary artery. Okay. So in patent ductus arteriosus, what will be happen? There is a connection between aorta and the pulmonary artery. Okay. So that's why blood is also here. Also blood is moving from left to right. Okay. So what actually happens here is blood is moving from aorta to the pulmonary artery. So that's why mixing of blood is also taking place. So how do you treat? We all know, no, these prostaglandins are responsible to keep open, duct open. No, here one ductus arteriosus is also present. So if I give this prostaglandins, no, it will open. So in this condition, the blood, look at, blood is going from aorta to pulmonary artery. So I want to close this. No, so I want to close this. So what I want, which drug I am going to give is like prostaglandins. If I give prostaglandins, it will open. So that's why I will be using prostaglandin inhibitors for this condition. So best example is NORCETs, non-steroidal anti-inflammatory drugs such as ibuprofen. Okay, if this is also not present, you can go, first preferred is ibuprofen, and this is not there, you can go for indomethacin. Okay, this is about PDA, patent ductus arteriosus, and treatment of PDA. And next we move to the obstructive lesion. So in this obstructive lesion, what is there? Coarctation of aorta. Okay, I will teach you what actually happens in this. So what do you mean by this coarctation of aorta is narrowing occurs. Suppose, imagine, so keep this diagram in your mind, you will tell the clinical features. So all same, left atrium, right atrium, and here is the aorta. In coarctation of aorta, what coarctation is nothing but this aorta will become narrow. Whenever aorta will become narrow, the blood flow to the distal parts will also become less, no? So the blood flow, whenever it will become less, what will be happen, like tell me, then the child will be having claudication, no? The child will go for some distance and he will be sit and will be complaining of pain and all, no? So he will travel for some distance and he will be feeling like lethargy, and he's like not at all active, so that is called as claudication. Okay, all your distal parts will be getting less blood, so that's why if I assess this femoral pulse, no, femoral pulse is also weak in this patient, so that is also known as radio femoral delay. Why? Because of this narrowing occurs. And next, claudication I have taught you, and you may find this hypertension in this patient. Okay, so this is the features of coarctation of aorta. Very, very important. Radiofemoral delay is seen in coarctation of aorta. Okay, and next is like chest x-ray. What are all the chest x-ray you will be finding? You will be finding this rib notching. Inferior part is rib notching is seen in coarctation of aorta. Don't worry, like I will be teaching the chest x-rays also. I will be teaching the all the chest x-rays in the single slide itself. That will be very helpful to revise at your revision time. And next, what kind of a sign you will see? E sign. Okay, or reverse 3 sign is also seen. Reverse 3 sign, where in coarctation of aorta. Okay, and now let's move to the cyanotic heart disease. So in cyanotic heart disease, first is tetralogy of Fallot. This is the most common cyanotic heart disease. Tetra is not, TOF is nothing but tetralogy of Fallot. Okay, so what tetra is nothing but 4 components. What are all the 4 components? One is RVH, right ventricular hypertrophy. One component is done, and next one is overriding of aorta. Aorta will come bit displaced from its actual place, that is known as overriding of aorta. Okay, and next one is your VSD, ventricular septal defect, and next one is your pulmonary stenosis. Please don't mark pulmonary stenosis, no. If I will write the order, sub pulmonary stenosis, pulmonary artery will become stenosed, no, pulmonary stenosis. So this is fun, subpulmonary. If this is not present in your option, you can go for pulmonary stenosis. Okay, so most of you, they will be studying pulmonary stenosis. That is right. If the option of the examiner, they have mentioned subpulmonary stenosis, go for subpulmonary stenosis. Okay, so this is about top components, very, very important. So all of the following are included in tetralogy of Fallot, except that kind of questions they may be asked. Okay, in pentalogy of Fallot, what do you mean by this? Penta is something 5 components. For top tetralogy of Fallot, if you add this atrial septal defect, you will get pentalogy of Fallot. And what is this trilogy of Fallot? RAP. R stands for right ventricular hypertrophy. A stands for atrial septal defect. P stands for pulmonary stenosis. Okay. So this is about triology of palate. So these are all the components you should know for your exam. So now let me teach you this look at the diagram carefully, and I will simplify this diagram for you. So I am teaching the treatment of tetralogy of palate. Okay. So if you know this treatment of an tetralogy of palate, look at this. What it actually happens is like, no, this is an pulmonary artery which I have mentioned in red. So in this black is your aorta. Okay. So I have written in red color is pulmonary artery, black is aorta. Okay. So now what is the treatment of this here is aorta is present over here, and one of these branches of an aorta, one is subclavian artery. No, here I am connecting this subclavian artery. So look at this subclavian artery to the pulmonary artery. So that is subclavian artery is connected to the pulmonary artery, that is known as classic BT shunt, Belloc-Towsing shunt. No, so we'll be studying BT shunt is used in tetralogy of palate and all. Okay, so this is classic BT shunt. Okay, and one more shunt is modified Gore-Tex BT shunt. Here also same. I am connecting this subclavian artery to the where? Tell me. So where you are connecting this subclavian artery? Subclavian artery is connected to the pulmonary artery. Okay, subclavian artery is connected to the, here also same, but here one artificially they are connecting. So artificially if they connect, if they use the word artificial, that is known as modified Gore-Tex BT shunt. So this is a second type shunt, and this is the most commonly preferred shunt. Most commonly preferred shunt is modified Gore-Tex BT shunt. Okay. So BT is nothing but Belloc-Towsing shunt. Okay. And what do you mean by this water stun? This is an ascending part. If I connect this ascending aorta to this red wala pulmonary artery, this red wala, this black is nothing but ascending aorta. If I connect this ascending aorta to pulmonary artery, that is known as water stun shunt. And one is pot shunt. If I connect this descending artery to the pulmonary artery, descending aorta to the pulmonary artery, that is known as pot shunt. Okay, these are all types. So remember, BT subclavian to pulmonary, modified Gore-Tex same subclavian to pulmonary artery, but here artificially I am connecting. And water stun, if I connect this ascending aorta to the pulmonary artery, that is known as water stun. Okay, so remember, here also A is there, here also A is there, ascending, and pots descending aorta to the pulmonary artery. Okay, this is about top. And what do you mean Epstein anomaly? What happens in Epstein anomaly is, we all be studying, no, lithium consumption leads to Epstein anomaly and all. So let me teach you. So right atrium, here tricuspid valve, right ventricle. Here tricuspid valve is not functioning properly, so that's why all the blood will goes into the right atrium. So that's why it is also known as atrialization of right ventricles. Okay, so here it is. What actually happens is like this tricuspid valve, it is getting displaced downwards into the right ventricle. Okay, so this tricuspid valve is coming to this right ventricle, that is known as Epstein anomaly. This condition is seen, so that's why you will find atrialization of right ventricle. Okay, what happened is downward displacement of tricuspid valve. Okay, this is happening over here. So what type of an heart? Box shaped heart you will find over here, box shaped heart. Okay, and next is mixing lesions. So very important, mixing lesions are increased pulmonary blood flow. Examples are truncus atresia, TGA, transposition of great arteries, and TAPVC, total anomaly of pulmonary vein. Okay, and what do you mean by this? TGA is nothing but transposition of great arteries. So what actually happened over here is, so all this, right, same story, right atrium, left ventricle, but here after left ventricle aorta will come, but in this condition here it is pulmonary artery. Okay, but here aorta will be coming. So aorta will be pumping what blood? Tell me. Deoxygenated blood. No, pulmonary artery, normally ulta is happening. Pulmonary artery should pump deoxygenated blood. This aorta is pumping the deoxygenated blood, but it will be keep on going like this, cycle. So that is known as parallel circulation. Parallel circulation. So this is also what kind of an X-ray you will find in TGA? Egg on string. Okay, this is a chest X-ray finding. So I will be showing all the chest X-ray in my next session. So let's move through the treatment offer over here. So here what you are going to do is like PGE1 infusion I should give. And next is like some atrial procedures I should perform. So very important, that is rash kind procedure. So if they are anybody asks where you will do this rash kind procedure, in TGA. Okay, and this atrial switch procedure is known as Atkins procedure. So this is a definitive treatment for TGA. Okay, so here TAPVC, next condition is TAPVC. So in this TAPVC, normally we know pulmonary vein, they will send blood to the left atrium, but in this condition this pulmonary vein, no, they are sending blood to the right atrium. This is known as TAPVC. Okay, so most common TAPVC is supracardiac TAPVC. So what it is like, no, this pulmonary vein, it will join superior vena cava. We all know superior vena cava where it is placed above the heart. No, so that's why it is supracardiac, above the heart. And if the pulmonary vein, it is directly connected to the right atrium. This directly it is connected to the right atrium, but not above, directly. That is known as cardiac. Directly into right atrium. Okay. And infravena cava is nothing but pulmonary vein. Now it is connecting to the IVC, inferior vena cava and all. So no, that is infracardiac, IVC. So ultimately the blood is going to the right atrium only. Pulmonary vein, it is connecting. This is an anomaly, no, TAPVC. And mixed variety is also present. And in both these, remember here, PGE1 infusion is contraindicated. Okay, so very important, please go through these concepts very carefully. And now let's move on to the respiratory pediatric respiratory. In the pediatric respiratory, you should know about all the, I will be teaching about all the concepts. So now we completed cardio, now we move to respi. So, if anybody asks commonest feature of upper airway obstruction, tell me what sound you will get if the upper airway is got obstructed? That is your stridor. So I will teach you upper airway obstructive disorders, that is laryngomalacia. Laryngeo is something known as larynx. Malacia is nothing but softness. Your larynx will become soft in this. So if you place the baby in the supine position, the stridor component will increases more. Okay, baby supine position, stridor is increasing, that is laryngomalacia. Okay, on laryngoscopy, if I put this laryngoscope and if I see the epiglottitis, in this condition the epiglottis, it will appears like an omega shaped epiglottitis is found over here. So what is the treatment? Tell me. Reassurance. Reassurance is the treatment in this condition. And next is croup. Croup is also known as acute laryngotracheobronchitis, ALTB. So in which age group this is common? 6 months to 5 years. Okay. So what is the major cause over here? Para influenza virus. So clinical complaint, stridor. This is also an upper airway obstruction. Stridor is present plus viral disease. So that's why fever will come into the action and cough is present. So how? Barking cough. Okay. These are all clinical features of croup. So what is this meant by mild croup is stridor is present and your SpO2 is normal. And here stridor is present at rest also and SpO2 is normal, that is your moderate croup. In severe croup, same stridor at rest plus your SpO2 value is abnormal. Okay, SpO2 normal. Here look at that, is it is in severe condition. Why? SpO2 is abnormal. So here you will find this hypoxia component. Hypoxia is less than 92%. Okay. So what are all the X-ray findings you will find? Tell me. Steepal sign. So no worry, I will show all the chest X-rays in my subsequent slide. So just remember X-ray of Steepal sign. No, if you look at the churches, if you see the church, no, there will be like this upside, this up thumb and all. No, this is like Steepal sign. I will be showing over there. And what is the treatment? Oral dexamethasone. And next oxygen. And next you are going to do nebulization with epinephrine. This is the treatment of croup. And next we move to acute epiglottitis. Remember, this is an medical emergency. Okay. So age group 1 to 3 years. This is the which age group it will get affected? 1 to 3 years. So this, remember, this is an bacterial infection. So which kind of an bacteria? Haemophilus influenza type B. H stands for Haemophilus. So what are all the features? Same. Fever but drooling of saliva. Very, very important. Fever, drooling of saliva. So I am writing in different colors. So only this statement is the key feature in the exam. Drooling of saliva. Remember, acute epiglottitis, fever, and baby is also having distress, respiratory distress. Think about this. Okay. So stridor is seen in 3 conditions: laryngomalacia and croup and acute epiglottitis. So how you can differentiate? By through the stridor? Tell me. No fever, laryngomalacia. Fever, think about 2 conditions. One is your croup and one is your acute epiglottitis. If it is viral infection, go for croup. If it is bacterial infection, come for acute epiglottitis. Okay. This is the treatment over here. So on X-ray, tell me on X-ray what sign? Chest X-ray. On chest X-ray, what is the what you will find? Thumb sign. Thumb sign. Okay. And what? How do you manage? By through the airway and plus antibiotics. Okay. So this is a bacterial infection. No, that's why I am going to give this antibiotics. And foreign body aspiration. So which is overall most common foreign body that will get aspirated in the child? That is peanut. So if it is not present, you can go for coin. Okay. Location where this aspiration, this foreign body goes and get lodged in the bronchus. So how does child will present? Sudden onset of cough. So here bronchi is involved, so that's why you will get choke, or he like you will get the wheeze is also present over here. Wheezing is also present, but here without fever. No bacteria, no viral. So there is an absence of fever. Bronchus is involved. That way you can expect wheeze over here. Wheezing may present. And how do you remove? If the child age is greater than 1 year, you are going to do this Heimlich maneuvers. Okay. And if the child age is less than 1 year, put the child in this prone position and you give this back blows. No, if it could not solve, then put the child in supine position and give this chest thrust. No, middle by using this middle and index finger. Give this chest thrust to the. This is about treatment aspect of foreign body aspiration. Very important. And next is acute bronchiolitis. So this is an, don't confuse acute epiglottitis and bronchiolitis. Bronchiolitis is a viral infection, this which I am speaking, but this is a seasonal infection, such as in winter season and in spring season you will find this. Most common is RSV, respiratory syncytial virus, RSV virus. So age less than 2 years. So how do you find clinical features? Fever plus bilateral wheeze is present over here. On X-ray, what you will find? Tell me. Your lungs will get hyperinflated. Hyperinflation. So how do you treat? Oxygen plus antiviral drug. Which is the antiviral drug you are going to use over here is? Tell me. Your ribavirin. Ribavirin is the antiviral drug. So very important. So now we have completed this, and now we move to most important of topic, that is pneumonia. What do you mean by the pneumonia? Consolidation of the alveoli. Now IMNCI has told that you should differentiate the pneumonia. Whenever a child will come to the PHCs, you should differentiate this pneumonia into three types. One is no pneumonia, pneumonia and severe pneumonia. So now let's look, if the no pneumonia is present, so how do you differentiate whether it is the pneumonia, no pneumonia and severe pneumonia? If the child is having fever, cough and cold, definitely this is present in all our viral infections also, no? So that's why this is a no pneumonia. So how do you treat the child? Home care based. Give this oral PCM, paracetamol to the child, okay? And next, how do you, very important, how do you diagnose the child is having pneumonia is by through the fast breathing or by through the chest indrawing. Look at this. Fast breathing is present, chest indrawing is present, but SpO2 is normal. That is the if you see these words, fast breathing or chest indrawing, go for the pneumonia. Okay. And how do you treat? Home based and oral antibiotics. Antibiotics should be given. What kind of an antibiotic you are going to give? Amoxicillin for how many days? 5 days. Okay. And in severe pneumonia, what you will find? This is always present. Fast breathing plus chest indrawing. In severe pneumonia, this is very important. Which? Danger signs. So what do you mean by this danger signs? If the child is having stridor, Sylvius, no? Child is, they will be using this mnemonic like a child is not able to feed and all. I will be teaching everything. So one thing, only three concepts: no pneumonia, pneumonia and severe pneumonia. No pneumonia, only fever, cold, no fast breathing or chest indrawing. If that is present, go for pneumonia. Along with that, if you find this danger signs, then you go for severe pneumonia. Okay. So for severe pneumonia, treatment is antibiotics. That as here you won't give amoxicillin, you will be giving this ampicillin plus gentamicin. This is the treatment over here. And one thing, all this they will come to the PHC, and PHC we want, after giving this, you should immediately refer the child. Okay. So some coding is given for if the no pneumonia, IMNC will tell that is green color is used if the child is having no pneumonia. If the child is having pneumonia, which color is used? Yellow color. Okay. And if the child is having severe pneumonia, which color? Red color. No. So that's why I will change my pen color also. Pink color. So most of the students, they have answered and came red color. So here pink color is used. That is Pink color indicates severe pneumonia. So that's why I have changed my pen colors also. Green, yellow and pink. Okay. And what is the criteria whether if you should tell the child is having the fast breathing or not is, so I told you no, in the pneumonia fast breathing is used. So what do you mean by this fast breathing is nothing but in 0 to 2 months child, if your respiratory rate is greater than or equal to 60 per minute, so then you can tell the child is having fast breathing. In 2 months to 12 months, if the child is having respiratory rate greater than 50 per minute, so that is like fast breathing. If it is greater than 12 months, then the child is having respiratory rate of 40 per minute. Okay. So these are all the values that you should know. So what do you mean by, I told you, danger signs. So danger signs were in severe pneumonia, color code pink. Look at this. So what are all the dangers is the child is not able to have the food, not feed properly, and the child is lethargic, cyanosis is present, and convulsions is also present in the child. Okay, these are all the danger signs. Now you know how to manage the child of pneumonia and all, no? So this one table can solve you all the questions. And next we move to the pediatric neurology. Very important, pediatric neurology. Like, so can you look at the IBQ over here? I'll zoom in. So which is this? So what? So how actually? Let me teach you what do you mean by this neural tubal defect. No, this at what actually happens. Why this neural tubal defect will come is in the baby, like neuroectoderm is present. If the neuroectoderm, after some days they will form this groove. Groove is present, and after that groove, this what will happen? This neuropore will be formed. If the neuropore, I will repeat my statement. Neuropore, anterior neuropore will develop to the cranial structures, posterior neuropore will develop to your caudal or spinal cord structures. Okay, so this is the function of neuropore. Okay, like neuropore, anteriorly it gives to cranial, posterior it gives to caudal. If it does not close, if this neuropore do not close, that leads to neural tubal defects. Okay, so that is the physiology, the pathophysiology, how this neural, if there is no proper closure of this neural pore, that is anterior or posterior neural pore, that leads to the neural tubal defects. Okay, if anterior part do not close, that is leads to your cranial disorders. So what is the best, what is the image which I am showing you in front of here is like anencephaly. Look at the, how we can diagnose. You look at the skull of the baby is not at all present. No, there is no skull only. So this is the best example of anencephaly. Skull is absent. Anencephaly. Best, like no skull or cranium or vault is absent. No absence of skull in the baby. And this is an caudal, this is the most common when compared to cranial. No, so look at that, this first one, this is known as spina bifida occulta. So what actually happens in the spina bifida occulta is, look at this is an vertebral bone, this is an vertebral bone. Here there is no vertebral bone, and here it is continuing, vertebral bones are continuing. So here there is an absence of vertebral bone in where, in spina bifida occulta. Absence of vertebral bones. Vertebral bone is absent in spina bifida occulta. And now you guys are getting right, like what is actually happen in spina bifida occulta. Your vertebral bone is absent in this condition. So which is the most common site? L5 to S1. This is the common site for spina bifida occulta, and you can find the tuft of hairs is present on the backside of the baby. And next condition is spina bifida cystica, or cystica is nothing but like cystocele is like, look at this condition over here. Here what it is happening is only meninges is get protruding. No, so look at this is known as seal, that is known as meningeocele. Only meninges is coming in that seal, or cyst is present. No, only meninges is coming, so that is known as meningeocele. And myelomeningeocele, look at the diagram over here, this is a myelomeningeocele. Along with the meninges, you will find spinal cord and some neural elements also. Everything is protruding, that is myelomeningiosis. Okay, this is about how to differentiate. IPQs are very important. Please go through this carefully. And how do you treat? Tell me. How do you treat? By giving this folic acid supplements. Folic acid supplements to the mother. No, if I give this folic acid, so what is the dosage? 0.4 mg. If the mother tells, if the previous baby has the history of neural tubal defect, then your dose will change to 4 mg. Okay, this is very important. So what is there any test to diagnose the mother is having this anencephaly or not? Yes, that is like markers. What are all the earliest marker is alpha fetoprotein. Okay, this is an sensitive marker. AFP is nothing but alpha fetoprotein and acetyl choline esterase. This is the specific marker. Okay, this is the specific marker. So this is about neural tubal defects and pediatric neurology. And look at this. Yes, this is an hydrocephalus baby. No, so what actually happens in normally? Tell me what is normal CSF levels in an infant's? 50 ml. In whom? In infants. Look at the head of the baby, it is bulged over here. In adult, that is 150 ml. There are two types of an hydrocephalus. One is obstructive. It is also called non-communicative hydrocephalus. And why it is occurring? This is the most common type. And why it is occurring? Because there is a blockage in this aqueductal stenosis. If the blockage occurs in this we all know, no, like from this choroid plexus, the CSF will be produced from that. It will reaches to the lateral, from the lateral ventricles. From lateral ventricles, it reaches to the third ventricle. From the third ventricle, it reaches to the fourth ventricle. In between the third ventricle and fourth ventricle, there is a structure known as aqueductal stenosis. Okay, if that will get blocked, if so, suppose imagine this is the lateral ventricle, this is the third ventricle, and this is the fourth ventricle, and here we will having aqueductal canal. No, so if there is a blockage in this, that is known as stenosis. So that leads to obstructive hydrocephalus, and this is the most common hydrocephalus. In non-obstructive, it is also known as communicative hydrocephalus. Communicative hydrocephalus. Okay. So here what is happening? If there is an increased production and decreased absorption. So we all know where this CSF will be produced in choroid plexus, where it will get absorbed in subarachnoid villi. No, so this is a problem in non-obstructive. Look at the skull of the baby. No, head of the baby, it is too big. So look at this. So you can see this prominent neck. This veins will also become prominent and all. So let me teach you like clinical features. So what is the clinical features you are going to see is macrocephaly. So head of the baby is greater than +2 standard deviation. And look at this. This is known as dilated scalp veins. I will zoom it for you. So look at this. So this is known as dilated scalp veins. Dilated scalp, no? Like you will find this dilated. So you can see these prominent veins, dilated scalp veins. So this is known as dilated scalp vein. And what this, no, there is a bulging of the anterior fontanelle where in hydrocephalus. And you can see the sunset sign. So sunset sign where it is seen in the eyes, no. So here the baby eyes is closed. If you look this upper part, no, upper whiter part, sorry, normally it is not visible, but in this condition the babies are, no, like this upper eyelid is above, it will get retracted and this white part will be visible. Okay, that is known as sunset sign. And it is also known as, if I auscultate over here, no, if I auscultate, like if I press over here, no, If I auscultate like this, you'll get the crackpot sign. That is also known as McEwen sign, where you will find in the hydrocephalus. Okay. Now I think you guys got all the clinical features. So macrocephaly, dilated scalp veins, and bulging anterior fontanelle, and sunset sign, and crack pot sign. It is also known as McEwen sign. Okay, McEwen sign. And how do you manage? By through the osmotic diuretic. That is your acetazolamide. And I will put surgery known as ventriculoperitoneal shunt. VP shunt, ventriculoperitoneal shunt. So what it will have? It will drain the CSF from the brain and it will send to your peritoneal cavity. This is the function of your ventricular peritoneal shunt. Okay. And if anybody asks, like after if you want to take the CSF for any blood sample, like for any blood, if you want to take the CSF, how you will take the CSF from the shunt? You can by through the shunt you are going to take the CSF. Don't answer and come lumbar puncture. No, by through the shunt. If the VP shunt is inserted, you can take by through the shunt also samples. Okay. CSF fluid, not only by through the lumbar puncture. You should not do lumbar puncture if the shunt is inserted. So this they have been asked. So this is about hydrocephalus, very very important. And one more thing, no, like if the baby will come to you by this meningocele or mylingo-meningocele and all, what you are going to do primarily, no, if the baby will come to the PHC or CHCs and all, like there you won't be having neurosurgeon, no. In that condition, what you are going to do is like you wrap around the take these gauze piece and soak it in the normal saline and you wrap around this. No, this is the treatment over. It has been asked in your exams also. Take the gauze piece and normal saline soaked gauze piece and wrap it around it. Okay, this is the and send and refer to the higher hospitals. So this is about myelinomeningitis. And next we move to the pediatric GI. And imagine a newborn is born and you will find the drooling of the saliva and difficulty in breathing. So then tell me, tracheoesophageal fistula. Okay, so like drooling of the saliva and difficulty in breathing in a newborn, tracheoesophageal fistula is seen in this condition. Okay, and like tell me which is the most common type of an tracheoesophageal fistula? TEF is nothing but tracheoesophageal fistula. That is type C is the most common type of tracheoesophageal fistula. So what actually happens is in this, no, like if I put this NG tube, there will be a coiling in the esophagus. If I put NG tube, you will find coiling of the NG tube. Why? Where? In esophagus. So what happens in this type C TEF is tracheoesophageal fistula is, suppose imagine this black color is the trachea and this is esophagus. This red color part is esophagus. So this is a proximal part. So in the proximal part there is an atrasia, esophageal atrasia. So atrasia is nothing but narrowing of the upper part of an trachea. Sorry, narrowing of an upper part of an esophagus, and this distal part it is get connected to the trachea. Okay, this is known as type C, which is the most common variety of tracheoesophageal fistula. Proximal esophagus is narrowing and distal part it is connected to the trachea. Okay, so this happens in the distal is like esophagus. No, distal esophagus it is getting connected to the trachea. Okay, this is known as type C tracheoesophageal fistula. Okay, so this is the most common variety, and now you should know like this is about TEF. And next, esophageal atresia. Sorry, it is over here. So esophageal atresia. So what do you mean by this is, this is the esophagus of the baby. Atresia is nothing but narrowing. So here what happened? The baby had a food, like feed, and mother has feeded the child, and you will find this recurrent vomiting. Why? There is a narrowing is present, so that's why it cannot go further. No, that is like vomiting. And this vomiting is bile stained? No, this is a non bile stained, that is non bilious. And drooling is present. Okay, and all these conditions, like in mother has the history of polyhydramnios. So this is about esophageal atresia. And next is CHPS. CHPS is nothing but congenital hypertrophic pyloric stenosis. Hypertrophy pyloric stenosis. Like what actually happens here is, like there is an hypertrophy of circular muscles. Hypertrophic of circular muscles. So whenever this hypertrophy occurs in the circular muscles of this pyloric part, in the pyloric part of the stomach, that leads to narrowing of the pylorus. So whenever there is a narrowing of a pylorus, sorry, mother gave the feed and the baby started vomiting. Why? The food cannot pass us further. Okay, so this actually happens over here. So name the drug. If the in the pregnancy period, if the mother will have this erythromycin, if the mother will consume this drug, erythromycin drug, the baby will get this congenital hypertrophic pyloric stenosis. This is the drug which causes CHPS. Okay, and I told you hypertrophy. Hypertrophy leads to narrowing of the pylorus. That food is not passing over further. No, so that's why here also same. Bile is not present. Non-bilious vomiting. So after vomiting, you will find this masses that is known as olive-shaped mass is seen in congenital hypertrophic pyloric stenosis. Okay. On investigation, what you will find? String sign. Okay, investigation string sign is seen in congenital hypertrophic pyloric stenosis, and this is very important. Baby started vomiting, so that's why chlorine is lost. So that is hypochloremic. And like vomiting, like your mucus is also get excreted. Like whenever mucus is get excreted, you will find this hypo Kalemia. Very, very important, which I am writing in this red color is very important. Don't forget that. So that's why I changed my pen color. So acid, so vomiting, acid is getting lost. So that's why metabolic alkalosis. Okay. If the child is having hypochloremic, hypokalemic, metabolic alkalosis, why? Due to this excessive vomiting. Think about congenital hypertrophic pylori. Lot of time this question have been asked. Okay, hypochloremic, hypokalemic, metabolic alkalosis. Why it is occurring? Vomiting leads to loss of chlorine, loss of potassium, and loss of acid. That is metabolic alkalosis. Okay, so how do you treat? By through the half normal saline, and if hypokalemia, add potassium, or you can give this ringer lactate also. No. So what is the surgery which is you are going to perform? Ramstead surgery. Ramsted's pyloromyotomy is the surgery which is performed in congenital hypertrophic pyloric stenosis. Okay, this is very important. So I have taught you and I have simplified for you. And duodenal atresia. So what it will happen in duodenal atresia is failure of recanalization of duodenum. So here vomiting, what kind of an vomiting? Bile stained, bilious vomiting. Double bubble sign is seen in duodenal atresia. On chest X, I will show you the X-rays, don't worry. Double bubble sign is seen in duodenal atresia. So what is the treatment? Duodenostomy. The treatment aspects, the surgery that is performed over here. So this is about duodenal atresia. And what do you mean by this Meckel's diverticulum? Next disease condition is, normally this remnant of omphallomesenteric and vitellointestinal duct, they should close after the birth. If it is open, then this disease will come. Which disease? Meckel's diverticulum. Okay. And remember, key point, painless lower GI bleeding is seen in where? Meckel's diverticulum. Painless lower GI bleeding, Meckel's diverticulum. Okay. And stool, what kind of a stool? Tell me. Red current. No, red current is intussusception. I will discuss. Current jelly like stools. Current jelly stool is seen in Meckel's diverticulum. Please go through this. And what is the treatment? Diverticulectomy. Don't confuse. No, like duodenostomy, diverticulectomy, and the name itself will indicate. No. So remember, rule of 2 is used in where? In Meckel's diverticulum. What do you mean by this rule of 2? It occurs in 2% population and 2 inch in size. Okay, and 2 feet away from iliocecal junction. Okay, and it occurs in 2 layers, that is 2 mucosa. One is, it involves 2 mucosal layers. One is gastric layer and next one is pancreatic layer. Okay, this is about rule of 2 is used in Meckel's diverticulum. And next, intussusception. This is the most common cause of intestinal obstruction between 6 months to 3 years. So most common site or most common junction is like, so what actually happened is telescoping of intestinal segment upon itself. Suppose, imagine this is the intestine. So what is happening? Telescoping. One intestine will come over here and one intestine will also come, like telescoping will occurring of an intestinal segment upon itself. Most common, ileocolic or ileocecal junction. Chief complaints: abdominal pain, red currant, jelly stools. Okay. On USG, what you will find? Target sign. Signs are very important. Where do you find the string sign and all? No, string sign where you will find CHPS, and also all the signs are very important. So this is about intussusception. And next is nothing but Hirschsprung disease. So what do you mean by this is like aganglionisis, like aganglionic megacolon. So like ganglion is get absent where? In the mesenteric plexus, and suppose in the stomach we have mucosal layer and submucosal layer. Okay, on this, in you and me, we will be having ganglion. No, but in this Hirschsprung disease, there is a ganglion. Ganglion is absent where? In mucosal layer, that is your mesenteric plexus and in your Auerbach plexus. No, if there is an what happens if there is an absent of this ganglion is, suppose imagine this is the stomach. Ganglion helps in peristalsis, movement. If the movement, if the ganglion is not present, the movement will not occur. Whenever the movement will not occur, the stool will get stuck. The stool will get stuck here itself, no? So that's why in the examiner hall they will always mention delayed passage of meconium. That is, after 48 hours also the baby is not passing the mechanism, this meconium, that is known as Hirschsprung disease. In which disease condition? Hirschsprung disease. Okay, why? This is the reason. A ganglion is not functioning properly, so that's why peristaltic movement is lost, the stool got stuck in this region itself. Okay, so this is an best. So this is very important diagnostic criteria. And per rectal examination, no, if I do this per rectal examination, after, if I do this per rectal examination, after I remove the hand, the stool will get expelled spontaneously. Why? That narrowing part will get dilated. No, after per rectal examination, the stool will get come out automatically by itself. So some surgeries are performed. So that is like, what are the treatment that tell me? Duhamel and Schwarz surgery is performed where? In Hirschsprung disease. Okay, very important. So all the slides, please go through the slides carefully. And next we move to most important topic, that is diarrhea. So can anybody tell which is the most common cause of diarrhea, whether it is a viral diarrhea or bacterial diarrhea? Yes, that is virus is the most common cause than bacteria. So what kind of a virus? Tell me. That is rotavirus. Bacteria, which type of an bacteria? E. coli. Which type? Extra toxin genal E. coli. ETEC bacteria. So virus is the most common cause of diarrhea. If that is not present, if they ask bacteria, then is your E. coli. Okay. So what do you mean by this? Dysentery is nothing but loose stool plus blood in the stool is known as dysentery. Most common cause for this dysentery is Shigella flexneri. Okay. This is the dysentery. Now this table is very important for your exam. Okay. So look at all the components carefully. So if you take this so what is the common complication of diarrhea? Dehydration. Okay. So look at the parameters very carefully. So here also same, no dehydration, mild to moderate dehydration and severe dehydration. And some dehydration is also known as mild to moderate dehydration. How the child is appearing? If the child is well alert, so nothing. So if the child is well alert, no dehydration. And in some dehydration, the child is restlessness or irritable. Child is very irritable. In severe dehydration, the child is unconscious, floppy or lethargic. Okay. And what about the eyes? This is about appearance. And next we move to the eyes. Eyes are normal. If they ask eyes is sunken, then it is some dehydration. If the eyes is very sunken, that is severe dehydration. Very important for your exam point of view. Dehydration, please get thorough by here itself and please look to the diagram picture very carefully. Thirst, if the normal child, he don't have any, he drinks normally, no thirst is present, but this thirsty is present in some dehydration. And if they drinks eagerly, so this is the confusing, most of the student drinks eagerly, they'll ask no dehydration. No, drinks eagerly is some dehydration. If the child will not at all able to drink or drinks poorly, that is your severe dehydration. Okay. And skin pinch I will do. If my skin pinch, if it goes less than 1 second in a child, that is normal. And if the baby is having delay, like the skin goes back slowly within the 1 second, no, that is like some dehydration. If it is goes greater than or equal to 2, that is severe dehydration. Okay, these are all the dehydration components. So now please go through this table very carefully. And now let me teach the treatment. In some dehydration, what, sorry, Okay, so now I will insert the table later. So in some dehydration, okay, let me write it the care treatment aspects. So now the table I will insert it later. So treatment, there is no dehydration, and next one is some dehydration, and next one is severe dehydration. Okay, if there is no dehydration, like nothing, no need to worry, treat by through the ORS. But in some dehydration, you should give ORS and you should give the fluid. By how? 75 ml per kg. Okay, 75 ml per kg per 4 hours. Okay, so in severe dehydration, IV fluid, that is RL, is given. So in severe dehydration, this is very important. I am giving this 100 ml per kg. Okay, so this 100 ml, no, you should divide into 30 ml per kg, and next 70 ml per kg. That is 70 ml per kg. Okay, so you cannot give 100 ml directly. You have to divide 30 ml and 70 ml. In the child age is less than 1 year, this 30 ml kg should be administered for 1 hour, and this 70 ml per kg, it should be administered for 5 hours. So totally you should complete all the fluids in 6 hours. Okay, if the child age is less than 1 year. If the child age is greater than 1 year, then what you are going to do? This 30 ml you should give it in half an hour, and next remaining 70 you are going to give in 2.5 hours. So totally you should complete in 3 hours. Okay, very important, where in severe dehydration, very important. And now come to this ORS. How much amount of an ORS? Composition of ORS, 245 milliosmoles. Okay, what is the sodium content in ORS? That is 75. Glucose 75. Sodium concentration and glucose concentration both are same. Chloride 65. Potassium 20. Citrate, and add all this, you will get 245. Okay. So why zinc is also given? No, ORS plus zinc you can also be given for the treatment. So why zinc is given? This is, they have been asked previously. It will help in epithelialization of GI tract. Okay. This is the major function why zinc is added to the ORS, epithelialization of GI tract. And it also decreases the stool, no, loose stools are present, so that also decreases the stool, and it also decreases the future diarrhea. And dosage, very important. In less than 6 months, 10 mg per day. If it is greater than 6 months, 20 mg per day. So for how many days you are going to give the zinc? For 14 days. Okay. And this is about diarrhea. And one is nephritic syndrome, nephrotic syndrome. I will be teaching now glomerular nephritic. So what is the hallmark feature of nephritic? Remember, itic. So hematuria is present. Hematuria, like hematuria is present in the kid. So if you look at this urine in nephritic syndrome, Nephritic, I am not talking about otic. Nephritic syndrome, hematuria, that is cola color urine, and the child will be having hypertension, and the child will be having oliguria. If you ask me if proteinuria is present, yes, but it is mild proteinuria and mild edema. Okay, so this is negligible amount, proteinuria and edema. So like if you look at this edema, what kind of an edema is present? Pedal edema or periorbital edema. These upper 3 points which I have wrote this, no, this is the characteristic features you will find in nephritic syndrome. Okay, and which is the most common condition that is associated with this is PSGN, posterior streptococcal glomerular nephritic, PSGN. Okay, and next is nephrotic syndrome. Remember O, hypomassive proteinuria, massive proteinuria, so that you won't get forget. Here also nephrotic syndrome O, proteinuria O, and hypoalbuminemia. Albumin will also become less. Hypoalbuminemia. Here also O, and edema. Okay. So here what kind of an edema? Generalized edema. Okay. These are all about you'll find in nephrotic syndrome. So what are all the disorders? MCD, minimal changeal disease. This is the overall most common disorder that is associated with otic syndrome. And FSGN, focal segmental glomerulosclerosis. Okay, this is about FSGN. So these are all the disorders that are associated with nephritic and nephrotic syndrome. And this is all about for today's session. So now we have discussed, so I have compressed all the topics that which is very essential for your exam point of view. So I have covered each and every point for, from cardiology to GI, respi, neuro and nephro and all. So this will be very helpful for you exam, and please go through these concepts carefully. Thank you for hearing us.